Hello guys, my name is Izzat Tayara. I'm from Palacky University and today I will talk about alteration of parathyroid function. It is essentially hyper and hypoparathyroidism, so an increase in the parathyroid function and a decrease in the parathyroid function. And yeah, we will talk about that. So starting with hypoparathyroidism, the definition is an excess secretion of parathyroid hormone because its main function is the secretion of the parathyroid hormone. As I think you heard in the physiology lecture, what the function of parathyroid hormone is. In like a summary, it's involved in the calcium metabolism. It acts on three organs: the intestine, the bones, and the kidney. And parathyroid hormones usually like increases calcium levels. We can classify hyperparathyroidism into three parts: into primary, secondary, and tertiary hyperparathyroidism. While there is like different etiologies between primary and secondary hyperparathyroidism, we will talk about that later, but like tertiary develops out of secondary hyperparathyroidism. Starting with primary hyperparathyroidism and its etiology. So the most common etiology of primary hyperparathyroidism is parathyroid adenoma, a benign tumor of one of the parathyroid gland, which has an oversecretion of parathyroid hormone. Another etiology, which is less common, like 5% to like 15%, is parathyroid hyperplasia, which would be an increase in the number of cells in all of the parathyroid glands. And in 1% of the cases, we can also have parathyroid carcinoma, which would be a malignant tumor, which also except like additional to the manifestations of hyperparathyroidism, would have also like may metastasize and cause like disease in other organs. Another etiology would be genetic cause. All of them can be genetic cause or could be also environmentally formed. But like genetic causes meant that it's part of like multiple endocrine neoplasia, which is like the most common. You can see again the different types with like the percentage. The pathogenesis of hyperparathyroidism is that we have like an increase in the parathyroid hormone, and this leads then to like increased bone resorption, as you probably heard in physiology, increase in calcium reabsorption in the kidney, decrease in phosphate reabsorption in the kidney, and increase in calcium reabsorption by the intestine. This is like indirectly through vitamin D and calcitriol. And this would lead then to hypercalcemia and hypophosphatemia. Okay, now we continue with like the clinical findings in primary hyperparathyroidism. As we like said in the pathogenesis, the result of primary hyperparathyroidism is hypercalcemia and hypophosphatemia due to increased parathyroid hormone without like the physiological action of like decreased calcium that like does not act on the receptors, causing like parathyroid hormone to be inhibited normally. So as is explained here in this like very nice graphic, hypercalcemia generally refers to the blood calcium level of above 2.5 millimoles per liter. In this case, like blood levels, so serum levels, are often taken as like total calcium. So this includes calcium can be found in the blood like free, which is calcium which is like physiologically active and does everything, but also like bound to albumin is also like involved in this total calcium. So as we say, as he's seen here, so in like patients that are sick and have like decreased albumin, there can still be hypercalcemia even though it was shown as like normal calcium levels. So as like also known from physiology, calcium is very important in like having like generally an effect on charge balance. And for example, like inward current of calcium causes like contraction of smooth muscles, um, etc., releases of neurotransmitters, etc. So when we have hypercalcemia, it alters the charge balance across the cell membrane, which leads that we have decreased contractility of the GI tract smooth muscle, which then leads to constipation, and it can also lead to a decrease of appetite, like anorexia. As well, there's an interesting mechanism with sodium channels on neuronal membranes to become more resistant to opening. This decreases the neuronal action, and in the central nervous system, it results in cognitive dysfunction, fatigue, and at neuromuscular junction, it leads to muscle weakness. As well, calcium, if we have like hypercalcemia, it leads that also more calcium will be found in the urine, so we will have some calciuria, hypercalciuria, as well as like phosphate, which is secreted, and this may lead to precipitation in the urinary tract and kidney stones, so nephrolithiasis, which may be then felt as like flank pain. Other like functions of calcium has memory function. It directly inhibits the insertion of aquaporine channels in the collecting duct, so less water is reabsorbed and more water remains in tubule filtrate, which leads into increased urine volume. There's also a decreased like calcium sensing receptor on the thick ascending limb, which has like a mechanism resulting also in polyuria. Polyuria, more water loss results in also like increased like ADH release, as well as like the hypothalamus is also signaled that that we need to drink more, so we have also polydipsia. Other like symptoms not listed here would be that hypercalcemia can lead to pancreatitis. This is a mechanism that is not well understood yet, but yeah, it exists as well. Other GIT symptoms include also hypercalcemia may cause like abdominal pain or peptic ulcer disease, because hypercalcemia also stimulates hypergastrinemia, so we'll have increased HCl secretion leading to peptic ulcers. And hypercalcemia may also lead to hypertension due to like the calcium effect on smooth muscle like contraction. Next, we're going to speak about hyperparathyroidism, and we directly will start with the etiopathogenesis. So the etiology that can lead to secondary hyperparathyroidism are like chronic kidney disease, vitamin D deficiencies, calcium deficiencies, or drugs. In this case, like chronic kidney disease, we speak about like renal tubular damage. Renal tubular damage may lead to decreased reabsorption of calcium, and decreased reabsorption of calcium will then lead to hypocalcemia, and hypocalcemia may lead to compensatory increase in parathyroid hormone secretion. Vitamin D deficiency may lead also to decreased calcium reabsorption in the intestine. Then we have calcium deficiencies, and drugs that act and lead also to calcium deficiencies will then generally lead to hypocalcemia and hyperphosphatemia, which would then increase the release of like parathyroid hormone and like compensation to get the values of like the calcium values, the calcium levels and the phosphate levels back to normal. So generally, we will not have clinical findings because, except like obviously the clinical findings of the disease itself, but like clinical findings like associated with the hyperparathyroidism will not be found due to like compensation to like normal levels of calcium and phosphate. In case of tertiary hyperparathyroidism, it is more an outcome of secondary hyperparathyroidism. That's why it can also be called continued progressive hyperparathyroidism. The etiopathogenesis is at the cause of secondary hyperparathyroidism, like we said, like chronic kidney disease, vitamin D deficiency, drugs, or even calcium deficiency through like any other cause. It will lead to hyperphosphatemia. Hyperphosphatemia will have like a mechanism acting on the parathyroid gland, leading to hyperplasia of the parathyroid gland, and this resets the calcium sensitivity and leads to increased parathyroid hormone with hypercalcemia, therefore having again the same clinical findings as described before in primary hyperparathyroidism. As I also forgot before, another additional clinical finding of like hyperparathyroidism would be obviously also bone disease. like osteofibrosis, osteitis, cystica, osteoporosis, because parathyroid hormone acts on the bones and causes increased bone resorption. Now we will speak about hypoparathyroidism. Hypoparathyroidism is the exact opposite of before. So we have a deficiency of parathyroid hormone, so decreased parathyroid hormone. The etiology is damage to or removal of parathyroid gland during thyroid surgery. This is the most common cause why we have like any kind of like thyroid cancer that has to be removed. The parathyroid gland may be damaged or removed with like the thyroid gland, and yeah, this may lead then to hypoparathyroidism. Normally, like if like we have like 4 parathyroid glands, if like 2 are removed, like we can have increased activity in the other 2, maintaining a normal calcium level, normal parathyroid hormone level. Genetic syndromes may cause hypoparathyroidism. We may have autoimmune hypoparathyroidism, like autoimmune disease, so like the immune system attacking the parathyroid gland cells. Hypomagnesemia explains the pathogenesis in a bit, or it can also be just idiopathic. So the pathogenesis is that decreased parathyroid hormone will lead to decreased calcium levels and increased phosphate levels, how we described before. So we will have like decreased bone resorption, decreased calcium reabsorption in the kidney, increased or decreased phosphate secretion, and yeah, this will then lead to hypocalcemia and hyperphosphatemia. Okay, now we'll continue with the clinical findings of hypoparathyroidism. As we said before, on hypoparathyroidism, the main clinical findings is based on the calcium levels. And in hypoparathyroidism, we said we have hypocalcemia, which is a serum level below 2.1 millimoles per liter. Interestingly, as well, as we said as well in hypercalcemia, we have now like the exact opposite happening in the body. As you would normally think, as you learned that calcium inward causes like neurotransmitter release, is associated with depolarization, etc. You would think that hypercalcemia, because of more calcium can enter the cell, you would think that would be associated with more excitability of the cell, while hypocalcemia will do the opposite. But actually it's the opposite, and this is explained here very nicely. Because we have less calcium outside the cell and we have no change in positive charges inside the cell, the intracellular fluid becomes like relatively positive in like associate like the difference between the intracellular and extracellular fluid. So we have a relative cellular depolarization, and voltage-gated sodium channels become more permeable to sodium influx, resulting in even like kind of like going towards an action potential. Therefore, we have like increased neuronal excitability, and we have cardiac myocyte depolarization, which results then in these symptoms like peripheral paresthesia due to and perioral numbness due to altered sensibility of peripheral nerves, and spontaneous action potentials in motor neurons, which leads to tetany, may also cause contraction of laryngeal muscles and laryngeal spasms and respiratory distress. We may have also like spontaneous action potential in the brain, which may lead to seizures. And generally, we have like a more hyperreflexive states. These are like clinical findings that you have like Chvostek sign or Trousseau sign, which can be an indication of hypocalcemia. Cardiac myocyte depolarization may be seen on the ECG with a QT prolongation due to delayed repolarization of the myocardium. And this is very rarely, but ventricles can contract at abnormal fast rate, leading to ventricular tachycardia, called torsade de pointes. So these are like the main symptoms and like clinical findings that you can have in like hypoparathyroidism and hypocalcemia. And this was also my presentation about altered parathyroid function. Thank you for your attention and goodbye.